Assalamu alaikum. Inshallah, today we will talk about lumbar canal stenosis and we will start with relevant bony anatomy of lumbar spine. This is the spinous process. This is the lamina, superior articular process, inferior articular process, and the connecting bars interarticularis again. This is the spinous process. This is the lamina, superior, inferior articular process, connecting bars interarticularis and the transverse process. This is the inferior articular process of the cephalic vertebrae. So, in between, this is the facet. In between, this is the facet, the facet, the facet, and so on. Second point I want you to know, from here to there and from here to there, this is the pedicular region. To enter your screw, you have your entry point is at this point. At this point, this is the intersection point between two lines, one in the mid-transverse process and the other one as the lateral border of the superior articular process. It's caudal part. So your screw passes like this. If you notice, there is nerve root coming just medial and around, medial and inferior. So if your screw is here or medially oriented, you will pierce on this nerve root. This is the spinal cord here. Two types of nerve come off this nerve root, here and there. This is exiting nerve root, exit the same level, and this traversing nerve root traverse the same level to exit at the level below. There is a triangular area which is a safe area formed laterally by the exiting nerve root and medially by traversing nerve root, and below at the apex below is the pedicle. So if I want to reach this disc area to do a discectomy, I have to put a retractor to protect this exiting nerve and put a retractor for the traversing nerve to reach and do my discectomy. Spinal canal is formed of 4 anatomical areas. From here to there is the central canal. Central canal. Between the two facets, subarticular below the facet is subarticular or lateral recess. So stenosis can occur here, or lateral recess, or foraminal below the pedicle, below this pedicle. And this pedicle is the rounded the nerve root which go around the pedicle medially and inferiorly in between this pedicle. And this pedicle is the foramen. Outside the pedicle is extraforamen. 4 possible anatomical areas for stenosis. So before going into soft tissue anatomy, this is the bony anatomy. Any osteophyte coming from any of these regions can press the spinal cord. But here is the inferior articular process of the cephalic vertebrae. So if I want to specify which is causing central stenosis in the central anatomical area, is the inferior articular process of the cephalic vertebrae. If I want to define what compress the lateral recess in the subarticular region, is mainly the superior articular process of the cephalic vertebrae. In reality, in real life, all are compressing. You have central and lateral recess and so on. So I have to decompress. If I want to decompress, I have to remove this inferior articular process, the lamina, part of the medial side of the superior articular process, to free the nerve root in the lateral recess, and going to the foramen to remove any hypertrophied ligamentum flavum, then going to the disc foramen to remove any ligamentum flavum, then going to the disc to remove the disc. This is the usual traditional sequence. This is regarding bony anatomy. Then going to soft tissue, ligamentum flavum, mainly ligamentum flavum. Ligamentum flavum is posterior to the cord and posterior to the nerve root. Ligamentum flavum has a special anatomical attachment. It attached to the under surface of the lamina above and superior border of the lamina below. So if I want to remove this, if I remove from the lower lamina, I will injure the spinal cord. I have to dissect, undermine the lamina above to detach the ligamentum flavum, then catching it, for example, with kerosene, and doing a decompression. Also, you can, another way, there are two halves. You can go in this side and try to freeing from the under surface on the spinal cord. This is the ligamentum flavum. So you have a bony causes of stenosis, any osteophyte in any area, and you have also ligamentous causes, mainly ligamentum flavum, also the capsule around the facet, around the superior and the inferior articular process could be hypertrophied and decrease the space. So spinal canal stenosis is reduction in the dimension centrally and laterally, causing what is called the neurogenic claudication. Please review lumbar disc disease and review spine examination. Neurogenic claudication means that the patient walking distance decrease. He informed you literally, I couldn't move more than 5 minutes, 10 minutes, 100 meter, and so on. This is called neurogenic claudication, and you have to differentiate it from the vascular claudication. We finished already anatomical classification: central, subarticular or lateral recess, foraminal and extraforaminal. There is also etiological classification, either congenital or acquired. Acquired, degenerative, mean osteoarthritis is the main cause of lumbar canal stenosis. Multiple discs, for example, not one disc. One disc is in young age is lumbar disc disease, lumbar disc herniation. Multiple discs causing decrease in the spinal cord at multiple levels. This is lumbar canal stenosis. This is the usual degenerative spondylitic cause. Most of the causes like this. Also, spondylolysis, when one of the vertebrae forwardly translated to the below vertebra, causing a decrease in the lumbar canal AB diameter. So, can cause manifestation of lumbar canal stenosis, or other causes like post-traumatic, post-surgery, and inflammatory. Also, there is a main congenital cause, which is short pedicle, mainly in achondroplasia. Short pedicle, this is the pedicle where I put my pedicle screw. If it is short, this is the axial view. If it is short, the AB diameter will decrease. The AB diameter will decrease, so lumbar canal stenosis can occur. Anatomical classification, again, central, lateral recessor, subarticular, foraminal, extraforaminal. Please don't forget central mainly by inferior articular process as a bony cause. Lateral recess is mainly superior articular process as a main cause for MCQ purpose. History and physical examination. We already finished spine examination. Please do a detailed, proper history taking and physical examination. Make your system as you want. I help you with my system. If not fit you, you can do another system, but don't forget any items. For example, you have to go for the main complaint, asking for the other three complaints, and relating everything to the function. Here, the patient mainly has a diminished walking distance in the form of neurological claudication. Neurological claudication, please review spine examination lecture, mainly starting from proximal to distal, the patient holding his thigh, then going to distal, vascular from distal to proximal. The vascular cause starting peripherally, then going proximally. And neurogenic claudication, what you will do when you have this pain, I will stop moving, then forwardly bend my trunk. His pain decrease when he going upstairs and increase while going downstairs. In the vascular, he has to sit. He has to take a rest, sitting, to decrease his pain. Of course, here is MRI finding, and here is vascular manifestation, and vascular investigation will be positive. I want to add in physical examination what type of pains. You have to differentiate between radicular and referred pain. Radicular pain we already took. Asia sheet, dermatome and myotome for key sensory areas and key muscle examination. For example, myotome, dermatome, L3 is just above the adductor tubercle, L4 just above the medial malleolus, first web is L5, and S1 is the lateral border. This is radicular. Type of the radicular is sciatica along the sciatic nerve, has a horrible causes, extraspinal, maybe by reform, maybe sacroiliac, maybe in the abdomen, whatever, in the pelvis. A lot of causes can cause sciatica rather than spinal causes. Referred pain, usually this pain not below, not a neurogenic claudication, not below the knee. Could be referred from the hip, could be referred from the inguinal region, and so on. So this is the main difference between these three types of spinal pain. Differential diagnosis, again, please review lumbar disc disease. You have extraspinal causes and intraspinal cause. Extraspinal causes mainly sacroiliac, mainly by reform, mainly hip, and also vascular. Please don't forget trigger point. We will give a simple note later on trigger points. Trigger points is one of the common mistakes which make some surgeons doing an unnecessary surgery. So you have to differentiate the extraspinal causes of back pain. You have also intraspinal causes. Intraspinal causes either extrinsic or intrinsic. Intrinsic inside the nerve itself due to, for example, diabetes. Extrinsic at the level of the cord and at the level of the nerve. Please again review lumbar disc disease lecture. Imaging, mainly AB and lateral to detect the cause. For example, spondylolisthesis. Mainly we need dynamic image, flexion and extension. flexion and extension detect instability. Usually you have an stenotic canal. So if you want to do some surgery for this patient, you will remove the elements, but you will need to do an instrumented fusion or no. This is according to the stability pattern of the spinal segment. Spinal unit is formed by lumbar body like this, disc, and lumbar body. This is together is a spinal unit. So detection of stability simply by doing flexion and extension. If there is translation forward and backward like this is unstable. If there is angulation like this in the disc space, this is unstable. Actually, there is a degree, but about more than 4 millimeter translation and about more than 10-degree angulation. But anyway, if you find any translation, you can consider it instability or angulation at the level of the disc space. So you have to put a screw with the fusion. If there is no, you can think that you cannot do a screwing. Of course, you are decreasing the operative time, decreasing the blood loss, and so on. But risk of further instability after surgery is increased. Anyway, dynamic views to detect stability pattern in the form of translation and angulation. MRI, this number you have to know. Cross-sectional area decreased less than 100 millimeter square. Also, you will detect facet and ligamentum hypertrophy. MRI is planning for surgery. For facet and ligamentum hypertrophy, to remove it as the two methods I give you. And obliteration of perineural fat. What perineural fat? This is the foramen. This is the ear-shaped foramen. This is usually in the upper part is the root, and below is the fat. Root and fat. Where is the root and fat here? It's compressed anterior and posteriorly. Compressed the anterior by the disc material and posterior by ligamentum flavum. This is the black one is the ligamentum flavum. If hypertrophied, going anteriorly. If going anterior, and if there is a disc material going posterior, compressing, sandwiching the nerve root. This is the disc. This is the ligamentum flavum. This is normally free, then going back, and this going AB anteriorly, hypertrophied disc, ligamentum flavum, and so on. Has a lot of degrees. Anyway, non-operative management is the rule for all spine. You have to consider non-operative. You have to wait and exhaust all non-operative patient methods. In the form of non-steroidal physiotherapy. Please, in the physiotherapy in the lumbar spine, concentrate not only on the back muscle strengthening and stretching. Please do abdominal strengthening and stretching exercise, weight loss, and again don't forget trigger point. Steroid injection is helpful. Please, steroid injection is mainly for radicular pain, not for back pain. So if you have a radicular manifestation in this patient, you can help him. If he resistant for medication, you can help him with epidural. Half of the patient do well with non-operative management. Please, again, exhaust all methods of non-operative management. So operative indication will be the reverse. The usual traditional two indication is failed medical and progressive neurological deficit, not a neurological deficit. Technique: decompression plus or minus instrumented fusion. For simplicity, traditionally open decompression. After posterior midline incision, you remove the spinous process, then the lamina and the inferior articular process, going through the safe triangular area between the exiting nerve root and traversing nerve root, doing discectomy, then putting graft with a cage inside the disc between the body. This is simple steps for the techniques. So this is what is mean decompression. You decompress the central part, you remove ligamentum flavum, you decompress the lateral recess subarticular region. This is the inferior and there is the superior. Then going to the disc, removing the disc and curate the end plates to make it viable for bone grafting and so on. This is decompression. What regarding fusion? I want you to know the main basic fusion technique is either from anterior or posterior. Anterior is ELF, anterior lumbar interbody fusion. And posteriorly, if you from posterior doing fusion without going anteriorly to the interbody to do discectomy, this is called posterior spinal fusion. Either putting the graft interlaminar or intertransverse. If you going posteriorly to do fusion posteriorly and going to anterior part interbody, this is called either PLIF or TLIF. And if you do the fusion posteriorly and laterally and the anterior, this is 360-degree fusion. All around, fusion all around. So what is the difference between PLIF and TLIF? PLIF and TLIF. PLIF is a medially directed discectomy, and TLIF is a laterally transforaminally directed TLIF. That's all the difference. So here in the PLIF, you will retract the cord much more medially to the other side. But if you go transforaminal, you will remove the facet and going laterally, so you don't need to retract the cord. So nowadays, the standard gold standard approach is TLIF procedure, either microscopic or traditional open. Again, you do discectomy through PLIF or TLIF, either a medial approach, which is PLIF, medial directed side of discectomy, or through laterally through the foramen after removing of the facet. Sorry. Complication. Usual complication: wound infection. If mild, you will continue antibiotic. If severe, you will do debridement. Usually in the spine, you don't need to remove the instrumentation except if it is loose. Migration of the cage. After you put the cage between the, when you're doing discectomy and curate the end plate, you will put a cage with bone graft to increase the union fusion rate, or doing dural tear failure to improve, and so on. This is an example of viva case. Just I want you to know one point. 70 years old lady, diminished walking distance. How you will manage? You have to take a proper history. You have to do a proper examination. A lot of causes can cause decreased walking distance. Don't concentrate on neurogenic claudication. Yes, neurogenic claudication is one of the main causes, but you have to know that there is extraspinal causes, and you have a causes at the level of the brain, at the level of the cord, at the level of the root, and so on. So don't focus. And he gave you this MRI, so there is stenosis mainly 4-5, some stenosis with hypertrophied ligamentum flavum. Here the diminished surface area of the canal and so on, then this is the image of his MRI. He is myelopathy. Please review cervical myelopathy. So please, there is other causes for diminished walking distance rather than neurogenic claudication. Thank you so much.